If you or your loved one has been diagnosed with liver metastasis, especially from colorectal cancer, one of the most important things we are looking at is timing. Specifically, when the liver metastases were found in relation to the primary cancer. Were they discovered at the same time as a colon or the rectal tumor, or did they show up months or even years after the primary tumor was treated? This distinction has a name. We call it synchronous versus metachronous metastasis. And while it may sound like a technical detail, it can significantly change how we plan surgery, how we think about prognosis and treatment sequencing. Let's break it down clearly, calmly, and with full context you deserve. What are liver metastases and why do they occur? Liver metastases are cancer deposits that start in another organ, most commonly the colon or the rectum, and then travel through the bloodstream to settle in the liver. This happens because the liver acts like a filter. Blood from the intestines flows directly to the liver through a large vessel called as the portal vein. So if cancer cells break away from the colon or the rectum, the liver is the first place where they land. Now, the presence of liver metastasis does not automatically mean that the treatment is not possible. In fact, in many cases, especially when the number of tumors is limited, liver metastasis can be treated successfully with surgery, chemotherapy, or a combination of the two. But how we plan the treatment depends in part on when the metastases are found. What does synchronous liver metastasis mean? Synchronous liver metastases are diagnosed at the same time as the diagnosis of the primary tumor, or within a short window, usually within 6 months. For example, a patient gets abdominal pain, a scan reveals a tumor in the colon, but the same scan also shows spots in the liver. This would be considered as synchronous disease. In synchronous cases, the liver and the primary tumor need to be managed together, and that clinical context changes how we plan the treatment timeline. What does metachronous liver metastasis mean? Metachronous metastases are those that appear later, typically more than 6 months after the primary tumor has been treated. Let's say a patient had a colon cancer surgery and chemotherapy, followed by clean scans for a year or two. Then during routine follow-up, a new spot appears in the liver. That's metachronous. It's important to understand a 6-month cutoff is not a strict biological rule. It's a clinical convention, a practical dividing line we use to group patterns of spread. It helps us to evaluate how aggressive the tumor may be and whether the liver metastases represent early systemic spread, that is in synchronous cases, or later disease evolution, like in metachronous. What timing tells us about tumor biology? In broad terms, metachronous disease is sometimes associated with less aggressive biology, and synchronous disease may indicate a higher tumor burden or a faster spreading cancer. But that's not always the case. We have seen many synchronous cases respond beautifully to treatment and many metachronous lesions behaving unpredictable. So we use timing as one part of the picture, not the only deciding factor. How timing affects surgical planning, the key differences. Here is where things get practical. Let's break it down a bit. In synchronous disease, we are often looking at 2 active disease sites at once. That creates questions like, should we operate both at once, colon and the liver in one surgery, or should we do it in 2 stages? Should chemotherapy come first to shrink the tumors, or should be given in between the 2 surgeries? In metachronous disease, the primary tumor is already treated, so we are focused entirely on the liver. But we need to be mindful of the liver function because the patient usually has received prior chemotherapy and also the time from the initial treatment to the current plan, because that changes the choice of our further treatment, and usually longer intervals mean a better prognosis. Common surgical approaches. In synchronous cases, options include simultaneous resection, where both the colon and the liver tumor are removed in the same single operation if technically it is safe. In stage approach, we operate the colon first only if the primary tumor is causing symptoms, like an obstruction. Otherwise, we address the liver first, since it's usually the more critical site of the disease. In metachronous cases, liver surgery is typically planned on its own, but we always assess, is there recurrence elsewhere? Is the liver lesion solitary or multiple? This has implications because if it's a solitary liver lesion, removing the lesion is all that is required and the patient does not need further chemotherapy. Is there enough healthy liver left behind after surgery? In both the situations, preserving liver function is as important as removing the tumor. Can both types be operated on? Yes, both synchronous and metachronous liver metastasis can be treated surgically. The key question is, can we remove all visible disease with clear margins while preserving enough healthy liver? That's where careful imaging, liver volumetry, and multidisciplinary planning comes in. If needed, we may use techniques like portal vein embolization to grow the healthy side of the liver, parenchyma sparing surgery to save as much liver as possible, or do repeat surgeries in metachronous cases if the disease occurs later. Common misconceptions even among professionals. This is an important point. Many patients and even some non-specialist doctors may have misconceptions about synchronous and metachronous disease. Some believe synchronous disease is always inoperable. That's incorrect. In experienced centers, simultaneous or staged surgeries can offer excellent results. Others assume metachronous disease is always less serious. That's not true either, especially if it appears soon after primary treatment. Some doctors delay referral for metachronous lesions thinking they aren't urgent, but early detection and timely removal often improves outcomes. And here's another misconception. If metastases are bilobar, meaning presence on both lobes of the liver, some assume it's automatically inoperable. That's also not true. Whether the disease is synchronous or metachronous, even bilobar liver metastasis can often be treated effectively with the right surgical strategy. That's why it's so important to have a team that understands the nuances of hepatic oncology and isn't operating from outdated assumptions. Some non-specialist surgeons also believe that if there are more than 5 liver metastases, it is usually futile to operate. That is also not true. We can operate any number of liver metastases so long as they can be completely removed with safe margins. What if liver metastases come back later? The patient often asks, if the cancer comes back in the liver after surgery, is that considered metachronous again? The short answer is we don't relabel it at all. Once a patient has had liver metastasis treated, any further recurrence is simply treated as a recurrence. And we manage it based on what is the site, how many tumors are present, the time since the last treatment, and the overall health of the liver. Sometimes we can still do repeat surgery or ablation or systemic therapy or a combination of these. The role of the multidisciplinary team. Whether the liver metastases are synchronous or metachronous, the decision making should always involve a multidisciplinary team, including the surgical oncologist or the liver surgeon, the medical oncologist, the interventional radiologist, and a hepatologist, and if required, even a transplant team. This ensures that the treatment is personalized, safe, and based on the most current understanding of liver cancer biology. So let's bring it all together. Synchronous versus metachronous liver metastasis, it's not just about dates and timelines, it's about understanding how the cancer behaves, how the body is responding, and how best we plan the treatment. Timing helps us predict the prognosis, choose surgery or chemotherapy first, sequence procedures correctly, counsel the patients clearly about what to expect, but timing is just one piece of the puzzle. It does not define what's possible, especially when the case is reviewed by a team experienced in liver surgery. If you have been told a tumor is inoperable because it's synchronous or bilobar, or that nothing can be done for metachronous disease, it's worth getting a second opinion from a specialized center that deals with complex liver metastasis. If this video helped you understand the real meaning and importance of synchronous and metachronous liver metastasis, please consider liking, sharing, and subscribing to our channel to stay informed. Our goal is to provide patients and caregivers with trustworthy, accurate information so that you can make confident, well-informed decisions. Thank you for watching.